I am Mani Chandran. I'm one of the geriatric psychiatrists working with Dr. Hanadi and team. It's my esteemed privilege to be here in this very auspicious dementia webinar. The section that I'm taking you through is dementia diagnosis, getting it right. No conflict of interest. So, well, why should we get it right? Well, like any doctor, any healthcare professional, any medical condition that we are dealing with, we have to get the diagnosis right. Yes, that's there. But what is more special related to dementia? The more important related to dementia is this is a diagnosis which has some serious implications. Because once we are saying this diagnosis, we are then saying that down the coming years, the person's cognitive abilities, mental faculties are going to be affected. Person's ability to make decision is going to get affected. So the need to make the plan for the future, whether they are at work or finished work, the importance to make the financial planning, to make the right planning in place before the cognitive ability gets further affected. So that's one. Then, of course, it has the medical legal implications that comes with this diagnosis. And equally and important is not to get the diagnosis wrong, because what happens is if we get the diagnosis wrong, say particularly in an acute care setting, patient is having memory difficulty or confusional symptoms, and we go and make the diagnosis, well, this is dementia. Well, sadly and unfortunately, we are not giving the patient the deserved care and treatment that the person needs, because delirium is a treatable condition. Once by saying it as dementia, there is an entire medical workforce apathy that sets in. The extensive investigations that are needed, the neurological evaluation that are needed to come to a conclusion of why the delirium is persisting. And so, unfortunately, an apathy sets in and everything gets looked into from a dementia window. So the patient, unfortunately, doesn't get what the person deserves. So those are the crucial aspects that we have to always make sure that we get it right. Few other things which are quite important we want to share as before we start getting into the diagnostic processes. All memory problem is not dementia. Okay, so that's important. The other important aspect that we share, an analogy that we share with our students and trainees is, if there is a patient who walks into a physician's consultation with a history of cough, he or she does not come out of the consulting room with a 10-minute consultation with a chemotherapy regime. That does not happen. The same principle has to apply for dementia. There is a diagnostic process that we have to do to reach to the diagnostic conclusion, and then only we have to look at the treatment modalities. So that's crucial. Now, so how do we go about? So what is the approach to dementia that we take, and how do we reach to making that diagnosis? Now, if we look at the brain, here, what is the main presentation? It's the memory loss. See, memory is one cognitive ability, which is time. It ties our thinking, our experiences, our perceptions to give us a meaning. Now, so it is a cognitive ability which is dependent on further other cognitive abilities, which are, which there are underlying several systems for those cognitive abilities. So a disease process can affect any of the systems, which can then manifest as a memory problem. So from that context, when we are looking through for an evaluation of a memory-related condition, the first very crucial that we have to look into is what it is not. So the person is presenting with a memory loss or a memory impairment. We have to make sure it is not because of delirium. Because if it is related to delirium, the evaluation, treatment, management approach is totally different. It is a curable condition. If we identify majority of the cases, we can cure the person. Person can recover fully from it. We have to ensure that this memory problem is not because of the 10-20 medication, the polypharmacy, the anticholinergic load that is there on the patient from things that we have done to the patient, medicines that we have given. So we have to make sure it is not the impact of the drugs. We have also got to make sure that it is not related to depression, which is one of the common conditions that affects the elderly. So we have to make sure that the manifested memory concern is not because of these things. So that's one priority. Then another important thing that we have to know is that as we look through it, we have to understand that the memory loss or a memory impairment, there are multiple differential disease processes that manifest with memory impairment. This list is not completely limited, but these are the most common and relatively less common condition that presents with memory concern. And as you can see, you have the Alzheimer's and the neurodegenerative conditions. You have the hypoxic injury following a cardiac arrest. You have the ischemic stroke. You have the limbic encephalopathy. You have the transient global amnesia, you name it. So you have these multiple differential diagnoses that is out there, which we have to ensure that in our evaluation, we have sort of thought through it, ruled those out as we are going into making the diagnosis of a neurodegenerative condition, dementia. So that is one way we can look at it. The other way that also we can look at it in looking at a broader picture of the things that affect memory. Second is looking at it from an etiological perspective. So when you look at etiological perspective, there are different etiological processes which again manifest on the memory domain. So on this, of course, you have the neurodegenerative, where you have the Alzheimer's, the Parkinson's, the Lewy body, the frontotemporal, the corticobasal syndrome, the progressive supranuclear palsy, you name it. What is the hallmark there for neurodegeneration perspective? It is usually the manifestation comes in the chronic domain. And say if you take the most common one, which is Alzheimer's, that presents with short-term memory impairment, episodic memory impairment, which then further progresses on impacting other cognitive domains. If you take the inflammatory infection, so you have the herpes simplex virus infection manifest, limbic encephalitis manifesting with memory disturbances. If you look at the inflammatory process, you have the autoimmune disorders, the antibody-mediated limbic encephalitis, the Hashimoto's encephalopathy. If you look from the traumatic point of view, you have the traumatic brain injury, which then is manifesting with, condition with bilateral temporal contusion manifesting with memory impairment. Equally, you have the chronic traumatic encephalopathy, the mild repeated traumatic brain injury, which is, mostly with contact sports like boxing, football, rugby. This leads to what is called as the progressive tauopathy and manifesting with memory and related cognitive concerns. On the other hand, if you look from the metabolic aspect, you have the vitamin B12 deficiency, the thiamine deficiency, which again, from the nutritional deficiency or, malnourishment aspect, or more importantly, from the Wernicke-Korsakoff of the alcohol related. So again, multiple etiologies there. From an endocrine perspective, you have the hypothyroidism, which is manifesting. From a vascular, the ischemic stroke or the hemorrhagic stroke, again, it's mostly the posterior circulation stroke, which serves the limbic circuit. So manifestation with memory can come apart from the anterior thalamic strokes. If you look from the episodic neurological side, we have the seizures, the transient global amnesia, and the migraine manifesting. So again, as you saw from the differential diagnosis aspect, from an etiological aspect as well, you have you can think through as you're ruling out the condition before we narrow down that this is a neurodegenerative dementia. So having looked at the broad conditions there, what other things that will help us in the process is to see the trajectory. the onset and the progression, the temporal profile of the disease process. So if it is an acute onset, like say within minutes to hours of a significant memory loss, obviously we have to look at from the person will need a structural brain scan. You're looking at and if there is abnormality in the brain, scan be it signal intensity changes or structural changes. Then you're looking at EEG to see whether there are seizure pattern. If there is a seizure pattern, obviously the management goes that line. If there is no seizure pattern, then you're looking at it from a stroke and other etiology. On the other hand, if the scan is relatively okay, then you're looking again potentially a seizure pathology or transient global amnesia or migraines. So that's when there is a manifestation is from an acute onset point of view. From a subacute onset, which is from weeks to days, again, there is importance to look at the structural scan. It could be signal intensity, structural changes, or more importantly, certain particular patterns like that we see in the CJD. So if there is an abnormality, then you're looking at the CSF in such scenarios. And from a CSF point of view, if there is pleocytosis, you're looking at an inflammatory or infectious cause of the CNS. High proteins, again, inflammatory infectious cause. Blood in the CSF, you're looking at hemorrhage or HSV. On the other hand, if there is no abnormalities on the CSF, we are looking at the toxic metabolic aspect, brain injury, be it traumatic or hypoxic, seizures, and CJD. If the brain scan otherwise is not showing us any structural lesion, then obviously we are further looking from toxic metabolic and endocrine disturbances. So that is from when it is a subacute onset. From a chronic onset, which is, of course, lasting for years, again, you look at the trajectory, the core symptom, the core cognitive domain which started. If it is a short-term episodic memory, more likely you're dealing with Alzheimer's and related dementias, could be Lewy body as well. On the other hand, if it was manifesting with memory retrieval problems, you're looking at FTD, vascular dementia, normal pressure hydrocephalus. The important thing here equally to note is that when the onset is with personality disturbances, social conduct disturbances, executive function, the high index of suspicion of FTD comes up. And of course, additional evaluation and investigation further helps you to clarify, to reach to the diagnosis. So having looked at the overall, the understanding on the differential diagnosis of the memory problem, the etiological differentials that comes through it, and the trajectory and the temporal profile which helps us to reach to a diagnosis, let us try to work through a real-life case scenario. So this is a gentleman. For the purposes of presentation, we'll call him as Mr. R. So 84-year-old gentleman comes to our clinic with his son. We start with the assessment process. And what do we see? Yes, he's smartly dressed. He's fairly alert and aware of where he is. But as he starts talking, he does not feel he has any problem. For him, I'm okay. That's what his response is. But very soon, as you start with the history evaluation, what comes through striking, the gentleman has difficulty in communication. He has word finding difficulty. And more importantly, he's not able to give you a comprehensive account by himself. So, of course, if this was a face-to-face session, I would have gone through interactive mode into those questions, but I'll tell you what we did. Yeah, basically what I wanted to say was this, because in scenarios like this, obviously we are not able to get the history. So we got a patient to be comfortable with one of our nurses. We sat with the son and went through the history with the help from son. So what are the steps that we follow in our clinic for evaluation of memory loss? So this is quite crucial and important. These are the multiple domains that we have to go through. So one is, of course, the history, which is our core. We go through the presenting complaints from the patient, from the family, and we go with additional elements on the history. Following the history taking, it is important to have a comprehensive physical examination and neurological examination. We assess the mental state, and then we have to assess the cognition, the tools that we use. In the clinic setting, we have MOCA, special cases, Edinburgh's cognitive examination, mini-cog, and more specialized scenarios, we will use full neuropsychology battery with help of a neuropsychologist. Following the evaluation from that aspect, we then go into blood investigation. Particularly, we have to make sure there is no hypothyroidism, there is no B12 deficiency, there is no folate deficiency, apart from looking at other infective and metabolic parameters. Where indicated, we go for a urine analysis. A look at the brain is important. So ideally, we ask for an MRI, but if for patient preferences, if they are not keen, then we go for a CT. Functional imaging also is important, and more recently we have started using more, particularly as we are getting more and more patients with early stages of Alzheimer's, manifesting like a mild cognitive impairment, very subtle impact on functioning. But when we evaluate them, they're scoring high on the cognition scores, cognitive tests. So we go for functional scan, and functional PET, FDG PET helps us to differentiate on the diagnosis. Specialized cases where we have neurological history, striking at us, then or it is a very rapidly progressive cognitive decline, we have to go for further evaluation, including CSF analysis. And of course, when there is any suspicion on seizure, we have to ask for an EEG. So these are the multiple layers on our evaluation. But if you ask me, where do we put the money in the diagnostic amongst all these, we would go for history taking. Because if the history does not match a diagnosis of dementia, well, it will not be a dementia. So history is the core that we will say, is the crucial element. But again, another important thing that we want to share with you here is that, it is not one aspect that is helping us in the diagnosis. Like what I'm trying to say, it's not that, my therapist does a MoCA and says, doc, this patient's MoCA is 3 out of 30. Okay, the diagnosis is dementia, take the medicine, off you go. No, that is not the case. MoCA is 3, MoCA is 3. We have to look at the holistic picture. The history, the examination, physical, neurological, the mental state, the cognitive assessment, the blood investigations, the scans. So it is the holistic picture, information from all this that we analyze, and then we reach to a diagnostic conclusion. Now, because history is important, let us just look at it a bit more in detail. So what do we do from a history point of view? We have multiple domains within the history that helps us in the process. So we have the cognitive domain. So in cognitive domain, what we are doing is we are looking at each of the lobe function, and we are taking the history related to each of the lobe to ensure whether there is an impairment, yes or no, and what is the trajectory and what is the pattern of the disease process. Some of the tools that will help us is informant questionnaire IQ code, or AD8, which helps to gather more information from the family and to complete the picture. Functional domain is another important area that we have to take. Again, here we are looking at the basic activities of daily living as well as instrumental activities. The point to note is that we are looking at what was the person's functional ability before the onset of the symptoms. So what was the baseline and where is it now? That is where we are looking from this context. This becomes more important, particularly in our diagnosis of mild cognitive impairment. Mild cognitive impairment is a stage where you have a cognitive impairment, but there is no impact on the functional aspect. So that is where, and because in dementia, the functional impairment sets in. Then very important to have a psychiatric domain. Now, this is very crucial because, time and again, this is where we tend to get wrong. Again, what helps us is the trajectory, the temporal profile of the history. We have had typical cases, we came across a patient who had a typical onset with clear-cut major depression with history of recurrent depression before. But obviously, as the disease process of the depression progresses, any of the psychiatric condition, when they reach to their severity, there would be an apparent cognitive deficit or apparent cognitive impairment, apparent memory impairment. So, in fact, for this patient, the diagnosis was kept as rapidly progressive dementia. But when we evaluated, patient was showing features of catatonia. The history for us went more like depression leading on to catatonia. We took her on, gave her ECT. She made 100% recovery. From where a MoCA she had 0, at the time of discharge, she's 30 out of 30, fully functional, independent, living by herself. Meaning we got her to live by herself. So that's where the psychiatric domain history is very crucial and very important. Then, of course, we have the neuropsychiatric symptom that we have to capture, as that is an integral component of dementia. Again, an aiding tool for that is the neuropsychiatric inventory. Safety domain is very crucial, because what you don't want, you make the diagnosis and the person off, he or she goes home and they are on 20 medication, nobody taking care, they are taking these medicines in their own way. It is an incident waiting to happen. So not just the medication risk, medication, wandering, fire safety, potential abuse, driving, all the safety domain we have to evaluate it and look at. Medical domain is equally crucial. The medical history, the surgical history, any medical episodes or events as the cognitive, either at the onset of the cognitive concerns or in the intervening process. Is this a recurrent delirium which is happening here? Is there a substance abuse there? Is there an alcohol issue there? All that becomes important. And of course, the entire list of medication that the person is taking. Frailty domain is crucial equally. Is there any visual impairment? Is there any hearing impairment? Is there any mobility concerns? Is there any falls? What is the hydration, nourishment for the person? Then it doesn't end there. We have to look at what is the support system. This is my patient, potential diagnosis of dementia. Where is the patient going? Who's looking after him? What is the care support system? And who's the carer? We need to see the carer. We need to understand who's the carer. Is the carer, what is the care? Is there a caregiver burden? So all these aspects from the history are crucial in completion of our evaluation as part of the diagnostic process. So coming back to our patient. So what we got from the son? We got from the son that there are clear cognitive concerns over the last 2 to 3 years preceding our consultation. And the pattern is clearly episodic memory impairment. That is how it started and progressed. So how was it presenting? Yes, it was presenting. He would not remember what he had. Like he would have had the food, but then he will accuse the children that they have not given him food. He would have prayed, but he will again go and repeatedly pray. And if anybody stops, he will become irritable. He will not understand, things that have been told to him. He will not remember that. He had visuospatial limitation, though he has been his house, 40 years, he's been living in the same house, which is very close to the mosque. When he's returning back from the mosque, he's losing way and, goes missing, and they have to, neighbors are bringing him back. Executive function disturbances, judgment and reasoning. The gentleman is a retired clerk, but before the onset of the symptoms, because he had multiple business, which he had given for rent. So he was very methodical. Start of the month, he will religiously go to each of his business establishments, gets the rent, go to the bank. So, his executive functioning, planning, judgment was perfectly there. Now what is happening? He does not know what is the day, which part of the month we are in. So the son has to take him, son has to prompt him. But then when he goes, he is not able to follow the instructions. Son helps him out. Then suddenly he will not remember that he has gone and will again go to the same place for the rent and ask and get into argument with them, thinking that he has not collected the rent when he would have actually collected it with the son. So all these elements set in. And then, of course, he was having significant incontinence and needing more enhanced self-care, particularly when he's in the washroom. Then, of course, we took the negative history. Negative history crucial because, as you looked at the diagnostic differentials, the etiological aspect, we have to make sure that there is no neurology, there is no psychiatry or things like that. So that part of the history. So no alterations in serums through the period of the 3 years of onset of symptoms. Rules out there was no delirium coloring the picture there, no psychiatric syndromes, no head injury, fall, or incontinence. Rules out the traumatic aspect, rules out the potential NPH aspect. No drug or alcohol history, takes away that element. Medication not on polypharmacy, is only on Pierre and paracetamol. The only relevant medical history is the prostate surgery, which was many years back. So otherwise, reasonably clean medical history for the gentleman. Has got a good support, lives with his family and wife and children. So having taken that, having got that picture, we were quite satisfied that that part of process is completed. Then we go on to the examination. From an examination point of view, well, we found him to be hypertensive with the readings as mentioned there. In a mental state, though, he was pleasant and cooperative. When we initiated further evaluation, particularly when we initiated the cognitive assessment with MOCA, he was extremely distraught and irritable. So we had to abort the test. Then we gradually persuaded him to do a mini cog. The condition in which he did mini cog, which is a short cognitive evaluation, rapid screen, but it still captures and helps us to know if there is a cognitive deficit. But the way he agreed for it was, he said, if his son does the test, takes the question, he will take the question. So that is how we did it. But clearly, Minikov, he had 3-item recall was impaired, clock drawing was impaired, so clearly highlighted short-term memory impairment, visuospatial impairment, executive function impairment. So clearly, we got 3 cognitive domains impaired there. Speech, overall, there was reduced spontaneity. His mood was reactive, as mentioned. No psychiatric symptomatology that we could establish otherwise, with clear lack of insight. So this, I would have put it if it was an interactive, meaning if it was a face-to-face session. But clearly what we want to highlight is, in our assessment, we have found a high BP, which even after repeating 1 hour in the clinic, it remained high. So we got him transferred to the ED. He was admitted to ED over 6 hours, and they established, yes, he has hypertension, and he was initiated on antihypertensive agent. So possibly an undiagnosed hypertension. Again, brings back home that, once the cognitive impairment sets in, the care component, the patient's ability to seek help for problems comes down. So here, fortunately, it was found. Coming on to the diagnostic aspect, as mentioned earlier in the slide, whenever we are going through a diagnosis, we have to make sure as we have ruled out all those other conditions through the negative history, we have to make sure that these 3 things are not there. So just to touch what particularly from a delirium point of view. So what is delirium? Delirium is a complex neuropsychiatric syndrome, which is acute in onset and presents with disturbance in consciousness, attention, orientation, associated with cognition and perceptual disturbances caused by physiological consequence of an underlying general medical condition. This is one of the important slides which helps us to differentiate between dementia and delirium. All these features help us, but if you ask me where I will put my money, the core feature which helps us differentiating is the consciousness. In delirium, the person is either hypo-alert or hyper-alert, whereas in dementia, the consciousness is clear. Other features, of course, aids into the process. Drugs. A biggie. This is not the full list. This is not an exhaustive list, but it's highlighting the most important ones, which is, medicines with high anticholinergic properties and relatively less anticholinergic effect. But our duty and our role is to ensure that we have liaised with the pharmacists, and if medicines with anticholinergic properties are there, if polypharmacy is there, we address it accordingly. This is just highlighting the prototype of presentation of depression, dementia, and delirium. As the slide says, depression, the patient is able to come, patient is able to express, whereas in dementia, it is a family member who is presenting. And of course, the consciousness is one which differentiates the other 2, where in delirium, the consciousness gets clouded. So coming back to our patient, so from the diagnostic criteria, does he meet? Yes, he has an objective memory loss. We have established that. He has an additional cognitive function affected, which through the short mini-cog test, we can have evidence. Of course, from the history, we have multiple evidence of executive function disturbances, problem solving, judgment, financial management, you name it. But here in examination also, we have established through the clock drawing impairment, visuospatial and executive function is affected. There is a clear reduction from his previous level of functioning. We have established that he's not having delirium. We have established he's not having any psychiatric disorder, and his symptoms have been standing for 6 months. So clearly, he qualifies for the diagnosis of dementia. Now we have to see what is the type of dementia the gentleman is having. That is where our investigation further helps us. Though clinically, if you ask, the pattern is episodic, progressive with other domains, and persistent progressive. It has all the features of Alzheimer's type, but we will try to establish it further through the investigations. We have to make sure. So blood investigation, things were fine. Looking at his brain. Now this is where, as you can see, as our neuroradiologist gives us the info. So you have the global atrophy. And if you look at the temporal, if you look at the hippocampus, if there is bilateral hippocampal atrophy, right more than left, with, of course, cortical atrophy and vascular changes as well. So looking at the impact, of course, our gentleman's condition stage-wise, it was slightly more than mild. In this moderate stage, as here you can see, there is a language is affected, memory is affected, there is a disorientation, recognition problems, there is a dependence, there are some behavioral symptoms, there is poor financial judgment. So moderate stage for our patient, and the caregiver burden was becoming evident. Son was finding it difficult to continue with his work aspect and continue to give all the care for his father. Unfortunately, later stages in the disease, like in severe stage, things would become more with incontinence, gait disturbances, speech and swallowing limitations becoming more. And as the stage progresses, the caregiver burden and caregiver stress becomes more. When towards the late stages, where they are fully mute, bedridden, the care component becomes more. And that is a time when the caregiver needs more support and needs more respite. So our patient working diagnosis, yes, we have made the diagnosis. It is Alzheimer's dementia with a typical clinical profile and our examination and findings. So just to go through overview of management. So we have, these are the 4 important steps in the management. Post-diagnostic support plays an important role, pharmacological management, non-pharmacological management, and importance on the safety aspects. So this is very crucial. We have to make sure we get it right, because this is where we are starting the journey. So what is crucial here? The crucial in post-diagnostic support is, it's not like we give the diagnosis and off they go. We give the diagnosis and we tell the family, particularly patient equally, but more importantly, the family, the caregiver, that we are here for them. This is a journey that we are taking together. They are not alone. That is the most crucial aspect, because the journey ahead is going to have its trials through and through. It is going to be difficult. And that confidence, that support for them is there. And this, obviously, we have our RAHA, our National Alzheimer's and Memory Services Helpline. We have a care support structure through that, where we help our family, patient family caregivers. This is crucial. So this is the nucleus of the post-diagnostic support. In addition, of course, we look at other aspects, which is making sure safety systems are in place, making sure the family is well aware of the planning in the future, the needs and support that they need, psychoeducation element, psychological support if the caregiver is needed, that structuring the day for the patient, helping him or her with all the community resources that are needed to help them through this journey. Now, important here is allocation of a care coordinator, so that the care coordinator and the family are walking through the journey along with the service support as and when it is needed. From a pharmacological point of view, yes, we have 2 groups of molecules. We have acetylcholinesterase inhibitors, which is our donepezil, rivastigmine, and galantamine, and we have the NMDA receptor blocker, the memantine. Obviously, as the slide highlights, in the mild to moderate stages of Alzheimer's, we can initiate with the acetylcholinesterase inhibitors. From moderate onwards, we can have a combination treatment along with the memantine. Specific here to specific conditions, point to note is in Lewy body type, rivastigmine and donepezil have much more efficacious role, but in frontotemporal, both the groups, acetylcholinesterase inhibitor or memantine, do not offer any much help. So this is just to highlight on the condition. Here is just to make sure that the dosage, that we start with a lower dose and then we gradually build it up over a period of 4 to 6 weeks. Important thing to note, both from an acetylcholinesterase group as well as from memantine, is to ensure and note that we have a baseline ECG. We have ensured there is no cardiac block, or the PR interval is not more than 200, because those are crucial aspect. Because unfortunately, these medicine, as they have the vagotonic effect. So if there is an existing block, that can become more and costs. It can become a contraindication, particularly if the PR interval is significantly high and there is secondary or complete heart block. So important in those situations that we are consulting with the cardiologist and following everything as advised by them. So there could be proportion of patients where we cannot give the medication. But even borderline cases, we have to closely monitor as per the cardiologist advice. Non-pharmacological treatment also plays a very crucial role, very important role. Again, the mantra here is person-centered approach all times. Cognitive stimulation therapy has got significant evidence base in the support, enhances the cognitive reserve. Equally, physical exercise, reminiscence therapy plays an important role. Psychoeducation with the family to continue through and through. We can talk more of it if we had more time to go through the details of the non-pharmacological aspects. Safety is paramount. It is important. So every assessment, we have to make sure that the safety domains have been evaluated and the right support systems are in place. Particularly from a safety aspect, we would like to share with you for the potential wandering risk in our patients. We have recently, with Dr. Hanadi and team, we have signed up with Orido, and we have got a GPS tracker device. It is going through its pilot phase. 10 family members are currently using it. And soon we will have the report from pilot phase, and then we will be giving it wider to our patients across Qatar who have an established diagnosis with dementia and are at high risk of wandering. So, but these all aspects have to be looked in as we walk through this journey. So here we're coming to the end of the presentation. I'm pleased to share here with this slide here. It's our Dr. Hanadi here. This is when she's receiving the award from WHO, where the Department of Geriatrics designated as WHO Collaboration Center for Healthy Aging and Dementia. The years of the journey that she took with her team coming to fruition with this recognition. On that note, I would like to say thank you for your kind attention and wishing you all a great day ahead. Thank you.